Welcome everybody at PCR London Valve 2024. I'm Chiara de Biase, interventional cardiologist in France, and we are here today to discuss one of the late-breaking trials of this edition of PCR London Valve. So I'm happy to be here with one of the top enroller of one of these late-breaking trials, the TRISCEND II, so happy to present Raj Makkar. Hi Raj, thanks to be here. So which is the rationale behind this trial?
We know that tricuspid regurgitation is associated with often disabling symptoms and increases the risk of death. We also know that repairing the tricuspid valve using the edge-to-edge repair technique produced some benefit in symptoms and quality of life. But often patients are left with a lot of tricuspid regurgitation. What we know is that with tricuspid valve replacement, you can actually abolish tricuspid regurgitation in most patients. So the magnitude of reduction is more. So the question that we wanted to answer is, if we use a highly effective therapy like tricuspid valve replacement, will we improve the symptoms and will we improve the quality of life in patients as well as clinical outcomes?
So it's a very smart question to ask before going for this trial, but I think it's even more interesting if we understand the population that you decided to treat, since you are talking about symptoms and outcomes. Can you give us some more details about that?
So for patients to be enrolled in the TRISCEND trial, they had to have at least severe tricuspid regurgitation. In fact, more than half of the patients actually had either even more severe or torrential or massive tricuspid regurgitation. And all of these patients had to be symptomatic and they had to be on medical treatment. So this was not supposed to be one versus the other, but can adding tricuspid valve replacement on top of medical therapy be better than optimal medical therapy alone?
So these are symptomatic patients under the best medical treatment. So which are the outcomes of the trial?
And the primary endpoint of the study was a composite endpoint of safety and efficacy. So it included endpoints like death and rehospitalization, tricuspid valve surgery, and then a number of quality of life parameters. Essentially, in a win ratio analysis, what we found was that the ratio was 2-to-1 in favor of patients that had received transcatheter tricuspid valve replacement with the EVOQUE valve, which means that patients treated with EVOQUE valve were twice as likely to benefit compared to patients who were treated with medical therapy alone. Now, I want to mention that primarily this benefit was driven by quality of life parameters. For example, the quality of life metric, KCCQ, which is a very important metric, increased by almost 18 points in patients who were treated with the tricuspid valve in a favorable direction compared to patients who were treated with medical therapy alone. And this magnitude of benefit is actually enormous. It is very similar to the benefit that is actually seen after the transcatheter aortic valve replacement in patients with aortic stenosis. So essentially, the primary benefit here was improvement in symptoms, improving functional status of patients, and improving quality of life.
I think it's very important message to say, if we have a severe tricuspid regurgitation and we have the possibility to treat this patient with this platform, for example, the EVOQUE one in this trial, let's go for that, because patients will really relieve from symptoms. So thank you very much, Raj, for these messages and for having been with us.
Thank you very much.